Hello, everyone. Welcome to today's Pulmonary Critical Care and Sleep Medicine Grand Rounds. I want to extend a warm welcome also to the applicants that are joining us through Zoom. It is my pleasure to introduce one of our STARS fellows, Dr. Shifa Gandhi. Dr. Gandhi came to us by way of the University of Pennsylvania, where she studied biology. Then she completed medical school at Robert Wood Johnson Medical School in New Jersey. Then she went back to Philadelphia, where she completed internal medicine at Thomas Jefferson. And I was looking at her CV, and she has this impressive list of accomplishments, long list of publications, presentations, but I would be remiss not to point out that what stood out was that she's a second-degree black belt with over 20 years of training in martial arts. So I know now I know the fellow that I'm not gonna argue with. She is currently under the mentorship of Dr. Erica Herzog and Dr. Wani Ryu, and she's conducting translational research in the field of sarcoidosis. Today, she's gonna present an in-depth look at sarcoidosis, and she's gonna explore the factors that contribute to the disparate clinical outcomes that we see in this disease. Without further ado, Shifa.
Thank you so much, JP, for that introduction. I also want to welcome the applicants. I hope your interview day is going splendidly. So I'm honored here today to be able to present Grand Rounds. We will be going into the social and biological determinants of clinical outcomes in sarcoidosis. This is just the CME information for anyone who needs it, and I have no disclosures. So this is a quick overview of what we're going to be diving into today, starting off with a little bit of history of this disease. So sarcoidosis was actually first described in the 1860s by a physician, Jonathan Hutchinson. He had a 64-year-old patient who came to him with raised skin lesions on her face and forearms. And these lesions increased in size over the span of 6 months. And so he basically called this Mortimer's malady. Then later on in history, Caesar Boeck, a Norwegian dermatologist, presented a patient to the Medical Society of Christiania, a patient with multiple benign sarcoid of the skin. He coined the term sarcoid because the lesions resembled sarcoma. And interestingly enough, he was also the first to describe the granulomatous histology of this disease. Later on, Hereford, who was a Danish ophthalmologist, described a syndrome called febris uveo-parotidia subchronica, and this was characterized by cutaneous lesions, uveitis, enlargement of the parotid and submaxillary glands, and paresis of the cranial nerves. Later on in the 40s, Sven Lofgren described Lofgren syndrome, a syndrome that we're probably a little bit more familiar with, which constitutes of fever, bilateral hilar lymphadenopathy, as we can see on this chest x-ray over here, and polyarthritis and erythema nodosum, as noted in this photograph. And so initially, this disease was thought to be solely a cutaneous disease, but now we know it can affect almost any organ system. And the development of non-caseating granulomas is the histological characteristics of this disease, as seen on this lung transbronchial biopsy. And so the immune response behind this disease is pretty complex. I just wanted to take a moment and talk briefly about it because some of the things that I'm going to mention we'll dive into a little bit later on in this talk. And so sarcoidosis is thought to be triggered by an environmental agent, which then leads to the immune activation of macrophages and dendritic cells, which upregulate the major histocompatibility complex expression. So we will mention MHC a little bit later when we're talking about the genetic aspect of this disease. So this also leads to the expression of cytokines that direct the adaptive immune response, such as the mTOR pathway, which leads to the differentiation of these epithelioid cells. And those are basically activated macrophages that resemble epithelial cells. This inflammatory response also leads to the upregulation of serum amyloid and heat shock protein. And this is more of the acute phase response. Followed by this, there's an aggregation of serum amyloid, which promotes enhanced effector T cell responses, in part through receptors such as toll-like receptor, another biomarker that we will be talking about a little bit later. And so in the presence of other cytokines such as IL-12, 8, 6, and TGF-beta, this promotes polarization of helper T cells, including Th1 and Th17. The impaired regulatory T cell response of things leads to chronic inflammation, which leads to chronic sarcoidosis. So this is the thought right now of how sarcoidosis develops, but obviously there's still ongoing investigation about which pathways influence which kind of targets. And so the diagnosis itself of this disease can be a difficult one because some patients have more of an acute onset, whereas others have a gradual onset. Some patients only have one organ involvement, others can have multiple organ involvement, including the lungs, eyes, and the skin. And so the diagnosis requires a couple of things. One is the compatible clinical and radiological findings. The next is the histological evidence of the non-caseating granulomas at the disease site. And lastly, the exclusion of other causes that can cause local granulomatous inflammation and local sarcoid-like reactions. And so as pulmonologists, we're most familiar with lung involvement. And as we know, this persistent inflammation can lead to architectural destruction, tissue injury, and fibrosis. And so when we're classifying pulmonary involvement, we use the Scatting stage system. And just briefly, since most people are familiar with the staging system, John Scatting was a British physician in the 1900s. And because around his time, chest x-rays were the main modality of imaging, that's what we use to classify. But now with the advent of CT scans, we can better characterize chest abnormalities, especially in stage 4. So going through this staging system, 0 is no abnormalities, 1 is hilar lymphadenopathy, stage 2 is that plus the parenchymal abnormalities that we see, 3 is just the parenchymal abnormalities without hilar lymphadenopathy, and 4 is fibrosis. So this is a chest CT with the classic nodular findings that we see in sarcoidosis. We see some scattered nodules here coalescing around the interlobar fissures with some architectural destruction. And then this is a chest x-ray and a chest CT with calcified hilar lymphadenopathy. Sometimes we can see atypical presentations as well. And so this is a patient with advanced pulmonary sarcoidosis with bilateral apical predominant cysts, as well as some bronchiectasis. And we can see honeycombing as seen pointed by the red arrow near the diaphragm, with the right lower lobe being a little bit greater than the left lower. This is a more common chest CT of stage 4 lung fibrosis. We see some fibrocystic changes, especially around the perihilar region, accompanied by ground glass. And so 10 to 30% of patients with pulmonary sarcoidosis, unfortunately, develop progressive disease. And it's thought to be as much as 60% of deaths are related to pulmonary involvement. About 70% of these patients also develop precapillary pulmonary hypertension. And when they do, unfortunately, this puts them in a worse mortality bucket, where the 5-year mortality rate is about 40%. So the other the other organ system that we also see with leading cause of death is cardiac involvement. It's thought to be about 70% of sarcoidosis death is because of cardiac disease. And so cardiologists use the Japan criteria to basically tell whether or not someone has involvement, which doesn't necessarily always require an endomyocardial biopsy. There are 2 main imaging modalities that they use, PET scans and gadolinium-enhanced MRIs. And so the MRI is a better test because it's more sensitive than a PET scan. So if you are concerned about cardiac involvement, usually this is the better test to get up front, whereas PET is usually used for monitoring disease activity. And so about 2 to 7% of patients with sarcoidosis have cardiac involvement, but it's thought to be that greater than 20% probably have some kind of involvement of their myocardium. And so looking at the picture on the left, that is a cardiac MRI, and the arrow is actually pointing to subendocardial enhancement. So at the bottom, we see a little bit less involvement compared to the top MRI picture, where pretty much all of the walls are involved. So about 4 to 10% of patients also develop neurosarcoidosis. The most common sites of involvement are the cranial nerves, meninges, and brain parenchyma. Some patients develop something called parasarcoidosis syndrome, and that's constitutes of small fiber neuropathy, which are painful hyperesthesias or dysautonomia, as well as fatigue and depression. And so the picture up here is a brain MRI with cerebellar lesions that are enhanced before and after treatment. So I mentioned Lofgren syndrome before. Over here in the US, it's relatively less common. We only see about 1% of sarcoidosis patients who present with this syndrome, whereas it's more common in European Caucasians, where about 1/3 of sarcoidosis patients have the syndrome in the Netherlands and Sweden. There are also differences in how women present versus men. And so women most commonly present with erythema nodosum, whereas men have arthropathies and arthritis. In more than 30% of sarcoidosis cases, cutaneous manifestation is the first thing that patients present with. And so it's convenient because it is an easy target for biopsy. The most common lesion that we think of is erythema nodosum, as shown in the first picture. But other skin lesions can include papules, plaques, lupus pernio, and subcutaneous nodules. So the last organ system that I want to mention is ocular involvement. The prevalence is around 10 to 50%, and it's higher in African Americans and in females. And so the common sites that we think of are anterior uveitis, as shown on the second picture, but we can also see lacrimal gland enlargement and conjunctiva enlargement. So those with uveitis usually have mild visual impairments. However, patients with long-standing involvement from ocular sarcoidosis with chorioretinal atrophy and scarring can lead to worsening vision, as shown in the color fundus in the first picture. And so it's important for these patients to get their yearly ophthalmological exams. So the death rate for this disease ranges from about 1 to 8%. And one study looking at mortality between 1999 and 2010 showed that the leading cause of mortality for these patients are respiratory failure and cardiac arrest. So steroids are the staple, are the mainstay for treatment of these patients. However, just like with any other medication, there's a plethora of side effects, which I won't go through, but this is a brief overview of all the treatments that are available. So usually steroids is first line, followed by steroid-sparing agents, including methotrexate, leflunomide, mycophenolate mofetil, azathioprine, and anti-TNF agents. So just as a quick recap, we've discussed the variety of clinical phenotypes of this disease, including mortality and treatment options. So the question I want to pose to you all is, why is there such a wide disparity in clinical outcomes in these patients? So moving forward, we're going to review the research that has been conducted on the biological and non-biological determinants, as well as review the research that's needed to bridge the knowledge gaps. So thinking a little bit about racial epidemiology, it is a challenging thing to study for a variety of reasons. First and foremost being the incongruent nature of self-reported race versus genetic ancestry. And so for sarcoidosis in particular, it's challenging because the fact that there's variable clinical presentation, as we discussed before, the fact that 30% of patients have spontaneous remission, and the fact that a lot of patients are asymptomatic. And so it can take clinician years to diagnose this. So looking in history, the 1950s was basically the turning point in which clinicians noted racial variation and differences in incidence and prevalence. So in 1990s, an analysis of race was done in patients who were newly diagnosed in Detroit, Michigan. And they found that the relative rates of sarcoidosis in African Americans compared to white patients was as high as 4-to-1. And this is a graph from their study clearly showing that African Americans had higher rates of this disease. So a more recent analysis of sarcoidosis based on healthcare use from 2009 to 2013 showed that the incidence and prevalence was also higher in African Americans. The top graph is showing that the incidence is around 17.8 compared to white patients where the incidence is around 8.1. And the prevalence is about 3 times as high. So we've established that sarcoidosis is more common in African Americans, but the next question to answer is whether or not they have a different presentation. And so a 1997 study actually done at Jefferson in Philadelphia looked at about 337 patients with this disease. These patients were divided into 3 different cohorts, one who underwent spontaneous remission, one who had induced remission with the use of steroids, and the third group who still had persistent symptoms even after the use of steroids. And they found that African Americans were more likely than white patients to have symptomatic disease and to have greater rates of steroid use. They also found that white patients sustained remission at higher rates. The caveat that I want to mention about this study is that the authors don't mention alternative treatments aside from the steroids. And they concluded that because African Americans were more likely to have severe disease, that's the reason why they were treated with steroids. In a review that same year in 1997 of bronchoscopy results from Walter Reed Army Medical Center, they looked at the yield of diagnostic endobronchial and transbronchial lung biopsies and found that the yield was higher in African Americans compared to white patients with sarcoidosis. And so they concluded that granulomatous inflammation in pulmonary disease was greater in African Americans. So if we see that they have more inflammation in the lungs, does this potentially apply to other organ systems as well? So the ACCESS study was probably one of the largest studies done in this patient population. It looked at over 700 patients with this disease across 10 clinical centers, and about a quarter of these patients had a 2-year follow-up. They found that initially 80% of subjects had improved or stable lung function, chest radiograph, and dyspnea scale. But at the 2-year mark, they noted that African Americans had increased rates of FVC decline, as well as new organ disease, including eye, liver, bone marrow, and extrathoracic lymph nodes and skin, whereas white patients had higher abnormal calcium rates. So a recent study actually that came out this year out of Johns Hopkins looked at cardiac sarcoidosis in a cohort of about 250 patients. They found that heart failure was a more common presentation in females as well as in African Americans. They also saw that the baseline EF was significantly lower for African American patients. They noted that there was no difference in timing of initiation of treatments. However, African Americans were more likely to receive steroid-sparing agents. And interestingly, they also saw that males were significantly more likely than females to experience post-treatment ventricular arrhythmias and therefore had higher rates of ICD placement. So these patients had a median follow-up of about 6.2 years. And some of the endpoints that they had looked at were LVAD placement, orthotopic heart transplant, all-cause death, and probability of event-free survival. And they saw that these things didn't differ by race or sex. So a quick summary of what we've discussed. We've demonstrated racial differences in clinical phenotypes, treatment, and mortality. And so I mentioned this in the Johns Hopkins study, that there were some gender differences that we saw. And so that's something that I want to dive into a little bit. So that same Michigan study that I had mentioned earlier, done in the 1990s, looking at new rates of sarcoidosis, actually showed that the highest rates of sarcoidosis were in females under the age of 40. And more specifically, it was African-American females, as noted by the red arrow. Whereas the green arrow shows that white females had the highest rate at a later age group between the ages of 40 and 49. The peak incidence in women and the peak incidence in general is thought to be a little bit more bimodal, where patients have a second peak at the age of about 50. And this is a graph showing that second peak in Scandinavian countries and Japan. And so this is a graph looking at a later coalition of mortality from 1999 to 2010. And on this graph, we clearly see that African Americans have higher mortality rates, especially in the age group of 55 to 64. What's not shown on this graph, but is mentioned in the paper, is that African American women, specifically under the age of 55, have the highest mortality rate. So moving into the talk, I want to mention, or I want to ask the question, why do we see these racial differences? So to think about that, I want to talk a little bit about socioeconomic impact. In the early 90s, ATS and CHEST produced statements that respiratory diseases disproportionately affected minorities. So multiple variables come into play when we're talking about socioeconomic status, including level of education, insurance coverage, geographic residence, and occupational exposures. So some could argue, as a result of our pretty broken healthcare system, African Americans we know are less likely to use ambulatory and preventative services, as well as have less physician contact overall. And so that Access study also looked at the impact of socioeconomic status on this disease. And they found that lower annual income was associated with worse dyspnea, as well as the development of extrapulmonary disease. Lower family income and the absence of health insurance was shown to be associated with more severe disease presentation, African Americans, women, and a later diagnosis of this disease. There was a different study that occurred in 2019 looking at a web-based questionnaire that also showed lower income patients had higher rates of new sarcoidosis-related comorbidities, as well as comorbidities from steroid use. They also noted to have lower health-related quality of life. And so this study actually came out in the 90s, which evaluated geographic variation in this disease in relationship to socioeconomic status in South Carolina patients. They basically looked at hospitalization rates between 1985 and 1995 and looked at various factors, including household income, physician density, health insurance. And they noted that basically this is broken down by race. On the right, we have new hospitalization rates for white patients. And then on the left, we have hospitalization rates for African Americans. And what you can clearly see along the coastline is this density of increased hospitalization rates in the African American population, which we don't see in their white counterparts. And so this coastal concentration was thought to be because of lower socioeconomic status of, around that region. So we've discussed gender influence as well as socioeconomic influence on sarcoidosis and outcomes. And then the last kind of bulk of this talk, we're going to focus on the biological determinants of this disease. So just as a refresher, the HLA gene is on a region on the short arm of chromosome 6. There are two classes, class 1 and class 2. Class 1 is expressed in almost all cells and basically presents a cytosolic-derived peptides to CD8 cytotoxic T cells, whereas class 2 has this alpha and beta heterodimer and presents endocytically derived peptides to CD4 helper T cells. And so one of the earliest findings that we saw were the relevant HLA genes in this disease. So HLA DRB1-1101 allele was found to be associated with sarcoidosis, and that was one of the earliest findings in the early 2000s. And then later on, we found multiple alleles that actually were associated with increased risk of progressive pulmonary sarcoidosis. The DQB1-0602 was found to have an increased susceptibility to sarcoidosis in African Americans in particular. And then lastly, the DPB1-0101, in addition to several other alleles, were also found to be risk factors for African Americans with sarcoidosis. So a couple of years later, in 2005, Lanuzzi and colleagues searched for sarcoidosis susceptibility loci by conducting a genome-wide sibling pair multi-point linkage analysis in about 200 African-American families. And they noted that chromosome 5q11.2 was sarcoidosis susceptible, whereas 5p15.2 was protective. With genome-wide sequencing that was developed later on, we found that annexin 11 was also had an association with this disease. It was initially sequenced in German populations, and then later with fine mapping, there were 2 variants found in African-American patients. So with the advent of gene sequencing, we made strides in further understanding the genetic basis for this disease and for the different phenotypes that we see. And so a lot of work has also been done here at Yale. Dr. Kaminsky, our chair, was the PI for this study that looked at genome-wide transcription analysis of BAL that was collected from the GRAD study. Our ILD center here was one of the 9 clinical sites as well for this study. And so the study was pretty complex, but some of the main takeaways was that there was association between certain genome pathways and pulmonary phenotypes. The first one that we saw was between helper T cells that was associated with hilar lymphadenopathy. We also saw an association between TGF-beta and mTOR signaling with parenchymal involvement, as well as IL-7 and IL-2 with airway involvement. And so this is a pretty complicated Sankey plot from that study, but I just want to make several points briefly. So the bars on the left represent genes that were associated with each clinical trait, with the height representing the number of genes. In the middle of the plot, we see positive correlation as noted by the yellow bars and negative correlation as noted by the purple bars. And then all the way at the end, we see the pathways that were studied. And so looking at the scatting stage, which is the second last to the bottom, that was significantly associated with about 166 genes, some of which were involved in the IL-1, 8, 6 pathways. And of these genes, many were also significantly associated with CT traits such as hilar lymphadenopathy and reticular abnormalities. What's not shown here, but was discussed in this study, was that genes increased in African-American patients had a significant overlap with genes increased with progressive scatting stage and decreased PFTs. And so this is also a heat map from that same study, and basically to identify gene modules associated with clinical traits that were relevant, they ran a weighted gene co-expression network analysis. And there's a lot of information here, but I just want to point out module 4. And this module had basically over 1,600 genes, and that had the positive associations are in red and negative are in blue. So this gene module was positively correlated with most CT imaging features, a BAL cell, lymphocyte and eosinophil predominant differential, and scatting stage. This gene module was also negatively correlated with macrophage differential in BAL, as well as FEV1 to FVC ratio. So this is a brief glimpse into this pretty complex study, an extensive study, which revealed specific gene profiles that correlated with activity and severity of diseases. So we've discussed the genomics in sarcoidosis, which lays the groundwork for determining specific biological mediators. The most common one that we think of is angiotensin converting enzyme, which we know is produced by epithelioid cells derived from activated macrophages, catalyzes angiotensin 1 to angiotensin 2, and metabolizes bradykinin. And so it's found in the capillary endothelial cells of the lung. And in 1975, Lieberman, who was a physician, was the first to report elevated ACE levels in sarcoidosis patients. So as we know, the sensitivity and specificity for this enzyme isn't great. This is a graph done from a study that looked at levels in about 3,000 people in Olmsted County, Minnesota, and they saw the sensitivity for the diagnosis of sarcoidosis to be around 41% and the specificity to be around 89%. So the management diagnosis based off of ACE levels isn't ideal because of the high number of false negative results. So soluble IL-2 was studied around the same time as ACE. The full human membrane-associated IL-2 receptor has 3 subunits and is expressed on activated T cells. Under some conditions, the alpha chain is released from the membrane, and that itself is called soluble IL-2. So soluble IL-2 is used to assess disease severity in several inflammatory conditions. A study done in Tokyo looked at serum samples of this level in about 70 patients, and they found that soluble IL-2 was higher in patients with active disease and lower in patients receiving treatment. Unfortunately, just like ACE, soluble IL-2 is pretty nonspecific and can be elevated in other granulomatous disease, autoimmune conditions, and hematological malignancies. So chitotriosidase has also been studied as a biomarker, and this enzyme is basically a chitinase that is involved in defense against chitin-containing pathogens. It has immunomodulatory effects that involves macrophage maturation, as well as non-chitin antigen presentation and stimulation of cytokines, including IL-8 and TGF-beta. So chitotriosidase activity was also found to be higher in sarcoidosis patients compared to control, and higher activity was associated with lung fibrosis as well as extrapulmonary sarcoidosis compared to those with just pulmonary involvement. And interestingly, they also found that in patients with sarcoidosis, there was a pretty strong correlation between this activity as well as ACE levels. Unfortunately, this is also elevated in other diseases, but can be potentially used as a tool to monitor disease activity. So looking at extracellular mitochondrial DNA, a lot of work has been done on this biomarker here at Yale. mtDNA has been shown to contribute to inflammation and tissue remodeling. It's a ligand for toll-like receptor 9. Remember, we mentioned toll-like receptor 9 on that immune pathway for the pathogenesis of this disease. And so mtDNA was quantified in 2 cohorts of patients with sarcoidosis, and above is some of their clinical characteristics. Here we found that BAL and plasma of sarcoidosis patients from each cohort had higher concentrations of mitochondrial DNA. We also detected high levels of toll-like receptor 9 activation in sarcoidosis plasma that correlated with their mitochondrial DNA levels. Looking at the clinical phenotypes, there was no association with fibrotic lung disease or with lung function. However, there was an association between plasma mitochondrial DNA and organ involvement outside of the lung. We also found that race was significantly associated with extrapulmonary disease, where African Americans with certain mitochondrial levels at a certain threshold were found to have increased odds of having extrapulmonary manifestation. And so it's really unclear the mechanism of mitochondrial DNA accumulation, whether it's necropoptosis versus trafficking through toll-like receptor 9 pathway. However, it's an interesting biomarker because we see clear racial differences in this, as well as extrapulmonary organ manifestation. So that poses the question whether or not there could be a toll-like receptor 9 polymorphism that explains these differences. The last biomarker that I am going to mention are telomeres. And so we have seen the association between telomere syndromes and ILD. The thing that we think of most often is the association between short telomere syndrome and IPF. And so within the IPF cohort, there are differences in telomere length based on sex and race. Studies show that the mean telomere length is longer in African American patients and that the mean length is shorter in males. So when we think of telomeres, we associate that with aging, and as we age, our telomere length becomes shorter, and there's a pretty linear relationship between the two. However, in these IPF patients, that linear relationship is pretty much disrupted. And so this study that came out this year looked at about 2,000 patients with pulmonary fibrosis. Their cohort was comprised of patients with IPF, connective tissue disease related fibrosis, interstitial pneumonia with autoimmune features, fibrotic hypersensitivity pneumonitis, and then the last bucket of unclassifiable. And this study was done across 4 tertiary centers. And we looked at data that was collected from 2003 to 2019. They basically showed that the mean telomere length was longest in African American subjects with pulmonary fibrosis. And the median telomere length was shortest in subjects with IPF, but longest with patients who had connective tissue disease-related ILD. And so telomere length in sarcoidosis has not been pretty commonly studied. There was a study done in Iran which looked at telomere length in these patients and found that it was shorter compared to healthy controls. They didn't find any significant correlation between scatting stage and telomere length. However, most of their patients were just in stage 1 or stage 2. They noted that with increasing CRP, telomere length did decrease, but there was no association between ACE levels or ESR. And so our study basically aims to identify biological and non-biological mediators that determine the phenotype of this disease. And what we are in the process of doing is looking at telomere length in patients versus controls. And we want to see if there's an association between telomere length and pulmonary disease versus extrapulmonary disease, and look at the effects of gender and race, because we know in healthy controls and in other ILD patients, there are clear racial differences that impact their disease presentation. We're also going to quantify mtDNA to look at the association between that and telomere length and disease phenotype. And so in summary, sarcoidosis is a complex and heterogeneous disease that disproportionately affects African Americans and females. And so studies examining this biology may ultimately help improve outcomes for these patients. So this is a thank you to everyone who is helping me in my research, and a warm thank you to all of my wonderful co-fellows who are amazing.
Testing.
Thanks, Shifa. That was awesome. Really interesting on the telomere. I actually had the question just thinking about potential bias in the way we think about sarcoid.
Mm-hmm.
I wonder if you have any thoughts on the fact that for a long time, any test questions that are written about hilar lymphadenopathy often include a racial identifier as the patient is African American. And do you think that that has the effect of keying us into thinking about it earlier so that we can identify the disease process? Or do you think it biases us away from a larger differential of what might be going on?
That's a really good question, because obviously we know that there are a variety of patients who have this disease. And so looking at the studies, it does show that African Americans present earlier with this disease and do have higher rates. So it's difficult to say, right? I'm not sure how to answer that question, honestly, but it is a good question and a good thing to think about when we're thinking about this disease, because that is the classic association, but obviously they can present in so many ways, right?
That was great. I have a bunch of questions, but I'm just gonna ask one right now.
Oh,
so
good.
The module thing's obviously really interesting to me, but the module that was like really correlated negatively and positively, do you know what like the genes that made up that module? Like,
honestly, I don't know the genes off the top of my head, because there were like 1,600.
Yeah.
But
no, I want you to name, can you name them all for me?
Yes,
sorry.
That's my quiz. But there were
like
genes,
usually they have like a theme.
like a theme, like the IL-8, 2, 6 cytokines. Those were some of the genes that were involved in that pathway. So that's why I kept mentioning those pathways.
Awesome. All right, I'm gonna get back to me on those 10,000 genes.
Hey, Shifa, thank you. That was great. So we're used to hearing about that clinical sexual dimorphism, but it seems that now you're starting to see some of this molecular dimorphism in your data. You're starting to see some of those biomarkers separate between men and women. And I wonder how you plan to incorporate that difference as you develop your project into, a multi-marker panel. If you think it's going to be necessary or helpful to separate into male and female, for example, when you do that assessment.
I think it will be helpful, because we know that in the non-sarcoid population, there are clear gender differences with regards to telomere length. And I briefly came across studies that actually looked at the effect of estrogen on telomere length in like mice models. So I think that's also a separate thing to explore, but it will be interesting to see if that has more of an effect versus race versus just the disease. I think it'll be hard to tangle out. Thank you.
Microphone just in time. So if I'm seeing a patient in Fellows Clinic who has sarcoidosis, what labs should I check each year?
Yeah.
And currently I'm checking all of them, but it doesn't seem like a good idea. So should I change that?
So
specifically ACE-IL-2 receptor.
Yeah.
And yeah.
It's a great question. And I think I'm going to defer this to the people who have seen a lot of sarcoidosis patients. But I will say one thing: if it's already established, then it could be useful to check some of these biomarkers for just to trend them to see how they're doing and see if there's any correlation with disease severity. But I don't know this biomarker alone if that's going to give you much information.
Thanks.
Does that seem fair, JP?
So there's like the soluble IL-2 receptor and the ACE level, we check it once, but it's not something that we're gonna trend. If anything, what we monitor yearly is going to be looking for signs of extrapulmonary involvement. In addition, so we get at least a yearly chest X-ray, PFTs. Then they need a yearly EKG, a yearly BMP, LFT. So you're looking for renal involvement, liver involvement, and then a CBC for bone marrow involvement. And that's on a patient that you're classifying as inactive sarcoid, that you're not treating, that you don't think they have active disease. Of course, if they have active disease, then we're monitoring that more frequently. Okay, so a couple of questions from Dr. Mate. So what is your hypothesis regarding the telomere length?
It's hard to say because African Americans in IPF have shown to have longer telomere lengths. However, these patients are significantly younger at the time of diagnosis. So my prelim hypothesis would be that they have shorter telomere lengths in sarcoidosis compared to white patients with sarcoidosis.
Yeah, and he was asking about relating to the disease activity and just pathogenesis among racial groups, which you kind of touched on.
Yeah, I think what we would see is that there is a relationship between that and disease activity as well as extrapulmonary disease manifestation. Just because that's kind of what we see in different cohorts, but the caveat is that the pathogenesis of this disease is different than fibrosis predominant ILD. So it's unclear what we will see, but that is what I think we will see, that it will be more severe and correlated to extrapulmonary diseases.
Yeah, I think it's interesting because in the DEGI paper, the Nature Communication papers, they look at fibrotic ILDs as a group, and it correlates with outcomes in all of them. But when you're thinking about fibrotic ILDs, you're thinking about this spectrum of fibrosis correlating to cell senescence. Mm-hmm. Sarcoidosis, like the pathogenesis is different, right? There's this inflammatory component. So I really don't know how it's kind of up in the air how it's going to play out. You showed the study from Iran, but that was like a small study. So I think it's still up in the air.
Because there's also a relationship between that and mitochondrial DNA. And it's thought that because of like oxidative injury, these things become affected. So it might be a different pathway in which the telomeres are affected rather than like the pathway that we see in IPF, for example. So we'll see.
Thank you. Thank you so much, Aoife. This was such a great presentation. I was like very interested in it. My question is, how are you measuring extrapulmonary presentations for patients? Because, for example, if you're saying like they have liver involvement, for example, like how are you measuring that? Is it just like AST, ALT? Like what standardized measurements are you using to
So basically it's a retrospective thing, and I'm going through all of the charts and seeing whether or not they have extrapulmonary manifestation. And for example, for the liver disease, that I would need pathology from a liver biopsy showing inflammation. So it's kind of just like looking through their notes, seeing what other physicians think, and like looking at the pathology.
Okay. It was just like, I've done the same retrospective study and looking through like charts for different organ involvements. And it's always difficult to figure out, like, if you don't have a biopsy of the specific organ, like how are you going to quantify if they have like involvement, you know, for like bone marrow, for example, are you looking through like their white blood cell counts to see if it's lower, like things like that? It's just very difficult to determine. So good luck.
I agree. That's a great point that you make.
Hey, just a question about what you guys are doing with the telomere length. Are you studying it in like blood cells or like any like tissue, or just in like the PBMCs?
PBMCs, yeah.
Cool. I mean, it should correlate, right?
Yeah.
I have one more question. Sorry, JP. I want JP to get as far over here as possible. So you kind of answered this question. Is there a potential relationship you're thinking about exists between telomere length and IPF and the proclivity for people with sarcoid to move towards that fibrotic stage 4 disease? Like, is there a relationship that you're hypothesizing exists?
That's a really great question. If we think that the mechanism is similar to IPF, then yes, you would see more disease with fibrosis. But then if we look at the mitochondrial DNA study, and if we believe that there's a relationship between mtDNA and telomere length in that group, then we didn't see that the mtDNA correlated with like lung staging or lung disease. It was actually with the extrapulmonary manifestation. Makes sense. So. Cool.
Yes. Kathleen saying outstanding work, Shifa. We share the sentiment. Great presentation.
Thank you.